Yeah, welcome everyone. Thanks for joining us this evening. We'll be talking a little bit about simulation in general surgery, how we do it at the University of Ottawa. So my name is Raj. I'm one of the PGY2s in general surgery. And then we have Daniel here, who's our program administrator, been coordinating all these events, along with Dr. Raish, who kind of leads our simulation lab among many other roles. And I'll kind of chat about like the experience of a junior resident and making that transition from being a medical student to a resident, and the role that getting time in the simulation lab has played in that. And then Dr. Raish will kind of give her impression on the curriculum as a whole and how that plays into our training as surgery residents. Maybe before I get started, if anyone wants to kind of introduce themselves and just tell us what school they're from. If people want. If not, that's cool too. I could just keep going.
Sure. My name is Joe. I'm from the University of Manitoba.
Awesome. Nice to meet you.
Yeah, thanks for hosting this.
Oh, no problem.
Hi, my name is Joanna. I go to school in Poland.
Nice to meet you, Joanna.
Thank you for hosting us tonight.
Yeah, that's why when Dr. Raish mentioned thinking about the timing, we want to try to make it work for people in different provinces, I guess different countries as well.
Hi, my name is Rosa. I'm from McGill.
So nice to meet you, Rosa.
I'm Tammy. I'm from UBC.
Awesome.
I'm Kira. I'm from Western.
Welcome. Nice. So yeah, we'll get started on the talk here. So essentially, objectives for my portion here is to give you a general overview of what simulation is and what skills we learn in it. And then we'll kind of talk about how its relevance is as a junior surgical resident. And of course, it'll be an informal session. So, I mean, we have some slides set up, but definitely take advantage of the opportunity to ask any questions that you might have about simulation, what it's like to be a junior resident, or really anything about the CARMS process. So simulation is essentially like learning in an environment that recreates or replicates like a real world clinical setting. So it's, as you can imagine, it's not the exact situation that you will be in when you're in the operating room, but it comes pretty close. And we'll get into some of the skills that we work on and how we work on them. And you'll see that it's quite a real replication of what we do in clinical practice. And the main there's a couple of different tenets to simulation training, but essentially it's an opportunity, especially as a junior resident, when you start off as a medical student doing electives in general surgery. You do little parts of procedures like closing skin or things that are relevant to your level, and then you have that jump to when you become a surgical resident, and staff are willing to let you take on more of a role in the operating room because that is why you're pursuing a surgical residency. So it gives you an opportunity to practice those skills before you get into the operating room, so that when you're there they're doing it on a real patient, it's not the first time that you're doing it. And we typically have our sim labs once a month, sometimes twice a month, depending on the scheduling. And each month we'll have a different staff proctor assigned to the session, so that when we're actually there and practicing all those skills, we're actually picking up good technique. Like, as you can imagine, if you're kind of just working through the motions of how you think you might do things, you might pick up bad habits and things that will be harder to unteach later on when you get into the operating room. So it's very thoughtfully set up to have a proctor there to actually critique the technique, go through the skills themselves, so that we're picking up good form. So one of the kind of categories of skills that we work on is kind of doing these fundamentals of laparoscopic surgery. I don't know if some of you may have seen these, maybe not. I definitely didn't see a lot of these laparoscopic platforms when I was a medical student. But essentially, it's like working on a skill, and it's kind of fun. It's kind of like a game where you're doing things like putting all these little beads with laparoscopic instruments onto little pegs. And we practice laparoscopic suturing. There's other things where you thread a knot through different holes on a board. And really what it does is, this might not be what you're doing inside someone's abdomen, but it really helps you work on those skills of depth perception, so that when you get into the operating room and your staff tells you to grab a grasper and hold something, you have a better sense of triangulating, knowing where you're going, knowing which direction you're pulling in with how much force. And I think Dr. Raish will talk a little bit about the value of this, and it actually helps, as much as you may feel that you're not going to be playing around with beads in someone's abdomen, the skills are very transferable. Another one of the high yield skills that we practice is doing laparoscopic cholecystectomies. And the SimLab has amazing resources where we have these pigs set up. We have their entire liver and the gallbladder embedded into the liver in kind of this box that you see here. And you could actually simulate what it's like to do an actual cholecystectomy in a real setting. And so everything down to the port placement, the camera that we use, the screen settings, and really the feel for holding the gallbladder, pulling it one way versus pulling it the other way, and kind of working on both sides of the gallbladder. It's one of those things that it really translates directly into skills that a junior resident can be expected to do and will be performing very early on in residency. And you'll find in residency that there are some cases that are way above our level, where there's other cases that are at the level of that a junior resident would be expected to learn and perform safely. And having the opportunity to actually practice doing a laparoscopic cholecystectomy goes a long way in being not only doing it, but being confident in doing it and doing it the right way in a real patient. And so I remember like the first time my staff, it was early on in as a R1 last year, my staff told me that it was my turn to take the gallbladder off the wall of the liver. And he asked if I have ever done it before, and I hadn't. But I had done it in the skills lab, and it really showed like that, practicing it in a safe setting where you could actually work on, moving your left hand and working on retracting and learning exactly how to get control of the cautery and those basic skills really translates into the operating room. Another skill station that we do is performing bowel anastomoses. And similar to a laparoscopic cholecystectomy, there are certain cases where performing anastomosis of bowel and connecting those back up is right at the training level of a junior resident. And staff are always happy to walk you through it. But when you have this opportunity to actually learn and go through and dedicate yourself to knowing the steps of how to perform a bowel anastomosis, your staff in the operating room will kind of know that you know the steps, and it'll kind of give them more reassurance in terms of trusting you in knowing how to do the procedure. And this is one of those stations where it's super helpful to have the staff with us during the sim lab to kind of walk us through the way they do the bowel anastomosis. But it's one of those things that you can do it once and you might remember how to do it for a couple of days, but you kind of need that repetition and kind of walking yourself through that mentally to actually perform it and perform it correctly. It's always a fun station, and there's Sam there, one of my core residents, testing out his anastomosis with, he just filled up the bowel with water and there's no leak. And another one here, I couldn't find a picture of any of us doing it, but this is like running the bowel. So essentially this station is, you have a huge loop of pig bowel in a box, similar to how the laparoscopic cholecystectomy was set up. And there's a bunch of balloons in there and clips attached to different parts of the bowel. And essentially the goals of this one are to pick up the bowel in a safe way without taking small bites where you might be injuring the bowel, which definitely can happen in a real setting, or when you're taking good bites where you could actually visualize both sides of the bowel and find all the clips. And again, this is one of those skills where you're actually working on your depth perception and your ability to know where your instruments are, being able to triangulate and working from different angles to just get more comfortable with the laparoscopic instruments. And we kind of talked about this as I went through the different skill stations. But essentially, I think, and all my co-residents would agree, that the sim lab is a great opportunity to review the steps and the techniques of a procedure and really hammer them down so that when it comes down to it, it's like second nature. And I think that's something that you'll find that is a recurring theme in residency, both in surgery and out of surgery, but a lot of repetition and knowing something really well ensures that when you're in a stressful setting, that you remember good habits and you're able to do the right thing. And again, the skills are very transferable. Everything from running the bowel to working on a pig gallbladder to moving beads on a peg. It really gives you a strong foundational skill set in terms of your depth perception, your control of the graspers, your ability to control the cautery without kicking back. And I think it took me a while to realize. I think early on, it was like, oh, like putting the beads on the peg is cool, but I want to work on a gallbladder or I want to do the bowel anastomosis. But you learn pretty quickly that all these little skills really add up when it comes down to doing it in real life and having those good habits that you've developed. And the one thing I really like about the sim labs is that it really mediates the transition between being a medical student and a junior resident. I'm not sure if any of you feel the same way, or I'm sure my co-residents do. But I remember starting off I remember being an elective medical student in general surgery. And I would get so excited when I get to suture the skin. And I still get excited about that. It's still really fun. And do little tasks like that in the operating room. And then I remember my first month of residency, and my staff was like, all right, you're going to take the gallbladder off the back wall. You're going to do this during this case. And my objectives as a resident were very different from my objectives as a clinical clerk on general surgery. And having that opportunity to actually learn those skills and practice those in a simulation setting, really helped me in terms of working on little things like knowing when I put in my graspers into the abdomen that I'm actually know how to find my graspers as opposed to fumbling around in there and making myself look like a fool. I mean, that still happens, but I think being in that sim lab and working on those skills really helps with that transition, because your role as a learner in the hospital, I found it significantly changes for the better when you become a resident, especially in surgery. I know medical school really trains us really well to be medical doctors, and we don't get that training to be surgeons because there's a residency for that afterwards. So it really helps having that sim lab to kind of mediate that transition. And I think that was it. We could do some questions if people have questions, and then Dr. Raish has a portion of her talk to give as well.
Do you see the question now? Do you see the we have questions on the chat, so
yeah.
so
yeah, so how much time do we spend in the sim lab in first and second year? So I mean, things have been a bit different because of COVID, but during the first half of first year, I think we had 1 to 2 sessions every month. And then we've actually started back up. So we've had 2 sessions already, the first one being in September, and we have another one at the end of the month. When we initially started before COVID, we had essentially a full day in the sim lab. From 8 a.m. to around noon, we'd be doing all these skill stations, and that would be the morning half. And then in the afternoon, we'd have the same staff that proctored us for the session give us a lecture. And it was helpful because you're getting some teaching at a junior level, and you also get to spend time and work with your colleagues. You'll find that you work a lot with the seniors on call and stuff, and you never really get a chance to work with your cohort. So when you're in there and you're working on a gallbladder with your co-resident, it's a very fun time.
I just had a question regarding the frequency as well, but is the once to twice a month for junior resident, or it stays throughout residency?
I think for a junior resident, I'm actually not too sure what the timing is like for seniors. I'll let Dr. H take that one.
Yeah, so for junior residents, it's the once a month is the goal, and sometimes it's twice a month because it's a week thing. But like yeah, so that would be one sim session, which is like a half day of skills lab. We replaced the lecture that happened once a month for a weekly lecture since the beginning of COVID, actually, for the junior residents. So those are not paired anymore. And then in terms of the senior exposure to simulation, they have two main, I guess, curriculum or skill set that we're working on at the Sim Center. So one is crisis resource management scenarios. Those are multidisciplinary scenarios that we run weekly. When they're running, we're not participating in them this fall, but we're hoping to restart them. And the goal of those sessions is for the senior resident to practice being a leader in the crisis scenario, either in the OR or in the trauma bay or something like that, just because we do realize that at our hospital, like the trauma team leader can be a surgeon, or it could be an ER doctor, it could be an anesthesiologist, but when the patients are really doing poorly, like chances are the surgeon is gonna, or whoever is the TTL, or if it's in the operating room, the surgeon is more likely to kind of take over. So we wanted to give the opportunity to residents to practice those skill sets as how are you going to communicate, how are you going to manage the team, practice situational awareness, avoid being fixated, all that kind of stuff that can happen in crisis. So we think that part is important. To practice that with nurses and with anesthesiologist, anesthesiology resident as well. There's a debriefing after those sessions. So the goal would be for the senior residents to participate in those scenarios at least once a year. And then we have, we were going to introduce last spring, and we're very proud of that. We're going to introduce the ATOM and ASSET courses that are kind of formal curriculum designed to, I guess, bonify trauma training, like it's kind of operative trauma training. And so those again are formal curriculum, and we're going to have like proctors from different institutions to come and train the residents. But again, like that all caught fire with COVID. So, and that happens on pigs and on cadaver normally. So those are the simulation that we have for the more senior resident is just a little bit more complex stuff, essentially.
Amazing. Thank you so much.
No problem.
And maybe if I can ask another question, is it accessible outside those hours of practice? Let's say you want to practice your laparoscopic skills a bit more. Can you go back on your own, or?
Yeah, the skill center is used to be accessible 24/7. Like if you have your ID badge, you could just get in there and practice certain skills. It's kind of they don't necessarily have the stuff out there for you to practice. So it's ideally you just send an email, tell them you want to go practice, and they'll get things ready for you. And that they're usually very welcoming with that. Again, COVID has changed a lot of things in terms of things being accessible and things like that. But normally the idea is that you guys can go as much as you want at the Sim Center. There's a question in the chat about the assessment. So I'm sure you guys have heard of EPAs before. So with the introduction of CBD, a lot of the skills have been divided into EPAs. And some of the EPAs have to be done clinically, meaning like in a real patient, in a real case scenario. Some of the EPAs are, it's possible to get an EPA just through simulation. So this is the first cohort, and those EPAs are for the core section of training, meaning usually what we used to think about as PGY 3 and 4. So none of our trainees are in that scenario at this point, but it's possible down the road that some of the more fine technical aspects of training are going to be done, like for example, if you need to sow a gram patch and you forgot to get your EPA, that when you saw a gram patch, then you could practice that at the sim center and get your gram patch EPA ticked off, kind of thing. That's the kind of thing that could potentially be happening. We this spring we didn't do it, but we used, and I think last year neither, because I usually was doing that and I don't remember doing it, but we used to score some gallbladder dissection for the junior residents to give them a sense of their skill set, and we would like to increase the number of scoring that happens every year so that people can have a sense of how their skills are progressing in the sim center. It is definitely an aspect of the sim center that I would like to improve, the number of assessment, like actual formal assessment we have, but that's a work in progress. Does that answer the question? Perfect.
So this is actually my first session hearing about sort of simulation and focus. And I was just wondering how do you say uOttawa sort of sets itself apart? Because obviously you've chosen to focus this information session on the use of simulation at the University of Ottawa. And so clearly it's something you're proud of. And I'm just wondering if you wouldn't mind kind of giving a bit of, at least the best of your knowledge, what the lay of the land is, and also what's really cool about Ottawa, because it sounds like obviously you're doing some pretty neat stuff.
Okay, well, what's cool about Ottawa? So I think my understanding, and again, it's hard to talk for other programs, but my understanding is that everybody has a sim center. So we have a really cool sim center, but everybody these days have a very cool sim center too. So that's not special. I think the thing that would be special is the simulation curriculum we have, and also the sort of dedicated time that we, like the protected time for the junior resident to go on a monthly basis. I think is probably more than what's available other places. And I can't talk for everybody, but I know that a few years ago we were running we ran a survey across the country to see how people were using their sim center and how they were deciding what skills were going to be taught at the sim center. And not that we're perfect at that, but like there was very few formal like curriculum designed for that. So I think the fact that we're anyway, I'm trying to implement like okay, so this skill we should try and bonify that. Let's get that at the sim center. Like the fact that we can have an approach like this, I think is a little bit unique. And also the collaboration with other specialty. Like I have one of my friend in Newfoundland, and she's been trying to get that started, and it's just not in the culture. But here we have a lot of good relationship with like because there's a fellowship program in Ottawa that's dedicated to simulation, and then you get to meet a lot of people. So there's kind of a network of like ER, OB, anesthesia, surgery that are all interested in simulation. So because there's like somebody interested in all those specialties, then we can create simulations together. And I think that's probably, I feel like it's unique to Ottawa, but I haven't been hanging out in other places.
Thank you very much. Yeah, I think the interdisciplinary stuff sounded really neat, just especially some of those trauma teams with, I mean, the nurses, the anesthesiology, I mean, the docs and the residents.
I've been debriefing a bunch of those sessions, and actually it's really interesting when you start asking nurses what they would like to hear during a crisis, and how if they knew what was in your head, kind of thing, like the stuff you think you've said and you actually didn't say at all, or the stuff that you think they understand but they like that's not actually clear what you said, or like when you're mumbling, like you when you're mumbling and you're assuming that everybody in the room totally gets it but like they don't. Like it's really neat because like realistically like that, I don't know what's your experience with that, but I know that you know, sometimes, let's say things are not going exceptionally well in the OR or during a trauma code, like it's not that frequent that people would take the time after to go like, okay, how could we have done better at this? Like what went wrong? And like, it's really nice to actually get like some very simple feedback on like we had one session, like, and one of the challenges was like the person who was supposed to lead this was a tiny, soft-spoken, young-looking female resident, and the person who was supposed to help her was this massive, loud guy, and so nobody paid attention to her. And like that was one thing we were debriefing, like, so how are we going to do that next time? Like, I don't expect she's going to grow much bigger, and I don't think she's going to get much louder, but she will have to, you know, get heard. So how do you do that? And then we talked about strategies, and there was a few soft-spoken ladies in the room, so we ended up, you know, giving tricks that we've developed with experience and stuff, and I think she got something useful out of that. So that was kind of nice. And I mean, nobody ever told me how to get people to listen to me, so I had to get that on, you know, on the spot. But like, I think it's nice. Like, I mean, she won't start her practice having to struggle with that. Like, one last thing, right?
Very cool. Thank you very much.
No problem.
So Dr. Raj, are these videos, sorry, when you said debriefing, are they recorded? So you scenario, you can watch it.
I'm sorry, I'm really struggling to hear you. I don't know if I'm the only one.
Yeah, I couldn't hear you too well either, Joanna. Partially, maybe. Do you want to type in your question and then we could try to answer it?
Oh, sorry. Can you
Oh,
hear me
yeah,
now?
we could hear,
I'm
yeah,
very
Oh, yeah,
sorry.
that's
we
great.
could hear you now. That's
Okay.
perfect.
Hi, Dr. Wright. I just wanted to ask, so when you meant debriefing, so you're watching everybody from a video recording? Was the whole scene recorded from a video and then you could watch it again together?
Yeah, so when we do debrief those scenarios, we can use so short answer, yes, we record the scenarios and then we debrief them after using the recording. Sometimes we use a little of the recording, sometimes we use a lot. Like, there's a temptation when you start recording things to replay the whole thing, but we've kind of learned with time that it's better to use shorter segments of it. But yeah, exactly, that's part of it.
Yeah, that's really helpful and innovative, but kind of also embarrassing sometimes if I have to, for example, watch myself react to things again. So
Yeah,
but,
I think that's one reason why we have this like, for that part there's no assessment, and we've been like really tempted to use that to introduce some form of assessment, but like we've talked about it multiple times and we just want to keep that a really safe environment. And then
like,
it's yeah, it's really meant to be like this kind of whatever happens here stays here, like nobody, like, you know, talk about what happens there kind of thing. It's like Vegas, but like in a better way. So you know, it's nice. And I know for residents and for trainees and even for nurses, because like they also get to learn, right? And for them it's, I think, even a little bit more uncomfortable because they're nurses in practice, like they're not trainees, right? Versus us, we're like, our residents are trainees, so they're there to learn, and there's the expectations that they're not going to be perfect. But I do know that a lot of people find that a little bit challenging. Like, that definitely pushes you outside of your comfort zone, but that's part of the challenges to run those activities, but I think they're beneficial.
yeah, I agree. Thank you.
No problem. Any more questions? Okay, I'm gonna go through my slides if that's okay. Raj, can you, oh yeah, I can just do it, right?
Yeah, you should be able to share there.
Yes. All right. Do you see my screen now?
Yep, we can see it.
Right. So I was gonna try and give a very like objective talk about simulation, and then I decided that that was a bad idea because clearly my bias are gonna show one way or the other. So might as well just embrace them and go for it. So I think simulation is useful. So this talk is about why I think it's useful.
If you haven't noticed, Dr. Raish really loves simulation.
Yeah, I do think I don't think we're using it as well as we should, but I think it has a lot of potential for sure. I'm working on it. All right, so why do I think it's so useful? Oops. All right, so that's an important slide, and it's the middle of the talk, but of the session, but I just want this to be super clear. So we're not taking attendance. Nobody's gonna remember who was here and who wasn't, or even like we'll have more town halls and we don't take attendance. We don't remember or record or keep track of who actually signed up for any of those sessions. They're gonna be recorded and available on the website, and we have no way of tracking, and we don't want to know who watched them or whatever. Like this is just for you guys. Very happy to see you, and none of this influences the selection process. It's just literally just a session for you guys to get to know us a bit better. And yes, welcome to general surgery at uOttawa. We think it's a nice place. So my objective for this is, again, to totally and fully biased explain to you why I think this is a good thing. This simulation is good and important, and then briefly explain how we created the simulation curriculum, which I think is something else that's important. Raj, you're going to be the referee for this part of the evening.
Okay.
As you notice, I like simulation a lot, and if I start ranting on something that's useless, your job is to stop me.
Sure thing, yeah.
I'll try to control myself. All right. Again, so that's a picture of the Sim Center at Ottawa. So the goals of technical skills simulation, which as Raj pointed out, is mostly what's happening for the junior resident. It's to provide a safe environment to train and to learn. So that's been shown. It's been shown that there's actual learning happening in the Sim Center. So there was this is not the reference, but there's a JAMA article from 2012 that looked at if you compare learning technical skills in simulation versus technical skills learning that might happen by watching videos or by learning from a textbook. If you get to practice it at the Sim Center, you'll learn better. So that systematic review looked at, I think it's close to 1,000 papers. And for once, the conclusion of the systematic review was that we should stop doing that study. So sadly for you guys, when you want to do research in simulation these days, you can't just say, oh, are they learning something? Because people have actually answered that question already. So you'll have to come up with a better project. And then it does improve patient safety, which I think is something that we're all concerned about, and something that as doctors we should all be happy to know and interested in. So there are a few very elegant projects to show that if you train people at a Sim Center, that actually has an impact on patient. So a classic one is one that was done in the ICU, where they showed that if you teach people in the Sim Center how to insert the central line, you have less pneumothorax. So that's one of the classic simulation paper. There's a few that have shown that if you practice maneuvers for shoulder dystocia in OB, you'll get less fracture in the babies. So those again, very elegant, like you practice, it gets better, there's less complications. So it's really hard to draw that line, but there's a few people that have been able to do that. Obviously those are now simulation research rock stars. So something to aspire. And that does decrease the cost of training for institutions. So there's some studies also that have been done looking at how much it costs to train people in a Sim Center, acquire the material, block the clinical time and stuff. And most of the simulators seem to be cost effective. So that's an argument for me to use with a program to justify sending you guys to the sim center, because it's actually, it's a good investment in resources. And then this is my favorite ultimate paper in the simulation literature, and it's getting old a little bit, but I still love it. And I butchered it. If you ever want to look this up, it's a really good paper. It was published in Annals of Surgery. It's a paper from Toronto, and what they did is they taught people to close. They had two groups. One group was learning to close an abdomen in the sim center. One group was reading about abdominal wall closure. And then they took those people and they took them to the sim center to. They took them to the sim center and they took them to the OR, and had the two groups closing an abdomen under the supervision of a surgeon, and with the surgeon reading them a script about abdominal wall closure, complications, hernias and stuff. And then after the surgery, they had the participants take a test on abdominal wall closure, infection, hernia, stuff like that, information that was contained in what the staff was reading or saying during the closure of the abdomen. And what's great about this study is that it shows, first of all, that the people who were closing the abdomen were better if they had practiced in a sim center. But again, we knew that from the other 2,000 papers that showed that. But what I think is the most important thing is that they were also much better at learning stuff about abdominal wall closure, infection, hernias that was contained in the script. So to me, that paper is the whole point of doing the sim. Like the whole reason, like Raj was telling you, we're gonna get you to practice removing a gallbladder from the liver bed. Like, I'm never worried that you guys after 5 years are gonna struggle to remove a gallbladder from a liver bed. But I would like you to be so comfortable by the time you get to the OR and you do that, that when you're doing a tough gallbladder and we're discussing like the finer points and how to handle tissue and how we should avoid complication about this and the more subtle things, then there's going to be space in your brain to learn that, because you won't be struggling trying to figure out how to get your hook to go where you want it to go. So to me, this paper explains why we're having a sim program in Ottawa in the first place. That was going to be my master's project. And then as I was doing the lit review, I found that paper and I was just like, damn it, they did it already. But I do think it's like the whole point. The whole point is to get your hands and your muscle memory going and good enough so that when you get in the OR, you get more from each time you show up to the OR. And then Raj talked to you a lot about that, but like there's a lot of skills that are transferable from the sim center to the OR. I'm old, so I get to put a picture from the original movies, but it's the same idea. Like whatever movie you watch with a training montage when like the person is practicing things that are not quite the real thing, but at the end they get really good at it. That's what happened with simulation too. Like there is a lot of things you can learn that can be transferred to the OR. So I was talking about with Raj when we were talking about this talk, and I was telling him like, you know, you can practice taking that gallbladder with your left hand, and then your left hand or your non-dominant hand, and then your non-dominant hand is going to be better next time you try to do something in the OR. You can turn the box around to try practicing like working backwards laparoscopically, which is pretty hard, and not that many people are born good at that. None that I know anyway. So you can get to practice that in the sim center. So when you like, again, like the whole goal of that simulation is not necessarily to get you to really good at removing a gallbladder from a liver. Like we know you're going to be able to do that, but what I want you to do is to get all your skills up so that by the time you show up to the OR to do whatever it is, as long as it's laparoscopically, because that's mostly what we work on with that, the gallbladder scenario, then everything is better. And that's also something that's been shown. Like people were worried about that a little bit, like, well, if you practice at a sim center, does it really transfer in real life, or is it so different in real life that it doesn't actually transfer? And it's true that some of the skills that you'll get at the sim center, and maybe Raj can talk about that, but even if you get really good at the sim center, by the time you get to the OR, it's a little bit harder just because like the pressure is different. There's much more distractions in the OR. There's a different kind of stress that comes with being in the OR, and especially for novice, that actually has a real impact on your skills. So even if, for example, if you're doing laparoscopic knot tying in the sim center and you're like tying like a champ, by the time you get to the OR, it's not unlikely to be just as elegant as it was at the sim center for a bunch of different reasons. Yeah, including the needle drivers that are different in the OR and at the sim center sometimes. Right. So that was my rant about the evidence behind simulation. There's a lot more than that, but this is the highlight. I tried to keep it a little bit short. So how did we design a curriculum for simulation? The fact that we entered CBD was actually really nice, because CBD sort of break down everything into little tick box. So then we just looked at all those tick box and went like, okay, this is what we can, and I have an Excel spreadsheet with like all the EPAs, and then just check like, could we do that at the sim center, and then ticked off everything we could do at the sim center. And then we have like where you guys are supposed to learn that with your different rotations, and when there's not enough X in the different rotations where you can learn the skills, then we had it at the sim center. And like, it's a very simple process that made my OCD feel really good, because it was all very well organized. So now I have a few more models to design for the sim center potentially, but it's like super well established, and we're just going to follow the recommendations from the Royal College. Like, they essentially did it for us this time. So it actually made our life much simpler. And it was kind of comforting for us as we were entering CBD to know that we actually felt equipped that way. And then as an example, like one thing we noticed is that the operative exposure for some of the trauma can be very variable. So if you talk with the residents and with somebody else than me, as I don't really do trauma, but I know that some people have a very busy trauma rotations when they do a bit of everything, and it's amazing. And some people have a different experience during their rotation, and all of a sudden they haven't seen all of those things. So because it's very variable, and because for example, all the traumas, they come at the civic. So if you end up doing lots of your residency at the general, then you are less likely to be exposed to trauma on call. Like, so many variables that can make your trauma exposure a little bit different. Then we decided to bonify the trauma exposure with 2 programs of simulation that I was talking about earlier. So Atom and Asset, which are just different things. So yeah, that's it.
Does anyone have any other questions at all?
What particular kind of surgeries are you expected to be able to perform after first year of residency?
I think like, and I'll let Dr. Raish touch on this as well, but I think like uncomplicated appendicitis, if it's like a straightforward appendix without perforation, that's something you could get through with some guidance from your senior or staff. And then definitely taking the parts of a cholecystectomy and taking the back wall off of the gallbladder. And then there's a lot of skills that you do, like depending on the rotation. So if you're on HPB, there's a role for the junior, there's a role for the senior. So doing a bowel anastomosis at the GJ, or if they're doing chole, you could help out with the open chole. I think in most cases, like the staff are really good at saying, you know, this is a junior level task that this is for you. And I know the civic colorectal group does that a lot, and to kind of identify objectives prior to going into the OR. So those are some of the things.
Sorry, I meant to say, so by second year, does that mean that you should be able to perform the whole surgery by yourself? Like, for example, an appendectomy?
I think definitely like a straightforward case, yeah, you could definitely expect to be doing that in R1 and in R2 as well. And depending on the case, I mean, you're always getting different levels of guidance. I definitely found that the technical work of doing a surgery is like only one very small aspect of it, and there's a huge mental component to it. So, you know, I could say, yeah, sure, I've done an appendix surgery, but have I truly done the mental work of doing it? I think that comes with time and just more exposure and practice.
Okay, thank you.
It looks like Dr. Raishi is going to go into one of her favorite teaching sessions.
Yeah, so that's another kind of simulation that we've been doing during COVID, and I'm hoping to be able to reintroduce that. So what we've been doing is we've been, like Raj was just mentioning, about the kind of aspects of surgery and how you make decisions in the OR. So that's a different kind of simulation, but that's also a kind of simulation. So what we've been doing is we've been having teaching sessions where we show those videos, and they're on YouTube. Like none of that's a secret, but I just edit videos and then transform them into like questions, right? And then we just go through those and we discuss them together, to kind of help you guys think through hopefully get you to think a little bit more like surgeons and kind of see what issues might be and how to work through certain challenges in the OR. So that's a videos of a series of questions about gallbladders, but we've done some on colon surgeries. I'm a colorectal surgeon, so that is easier for me, but those are some of the stuff we've been doing as well. And I think, I don't know, Raj, you might talk to that and pretend I'm not here, but I think you guys were finding that useful, right?
Yeah, it was actually super useful because like the number of times that you're in an operating room, you're watching them do the surgery and kind of going through the thought process and kind of going through these questions in terms of what are the critical things that you're thinking about when you're making a decision intraoperatively. That really helps in terms of actually getting into the mind of the surgeon and like I said, learning the mental aspect of the surgery. And so when you're in the operating room and you see them doing this part of the case, you could kind of pick up on different things that you may have not have appreciated at the last time you watched someone do the triangle in a cholecystectomy. So I think that's something that's definitely very helpful, especially when during COVID, when we couldn't go to the sim lab. Having these sessions that Dr. Raish put on for us were super helpful.
Yeah. So yeah, it's just a lot of discussion and getting you guys to practice decision making, hopefully. All right. Any more questions? You can ask questions about the program in general. It doesn't have to be only about simulation.
I had one last question about the simulation. So we mentioned that staff are heavily involved in supervising residents, but I was just curious, should a senior resident be interested in teaching their junior fellow residents? Could they like join one of the sessions and support their junior residents in learning at the sim center?
There's we would welcome that. Like, I don't think anybody would say no if a senior resident wanted to go to the sim center to teach. I think it's an availability issue. Like, I think the senior resident tend to be a little bit busy. But if a senior resident had at time wanted to or chose to, I think would be very happy to accommodate for that. It hasn't really happened lately, to be honest, but I think it has to do more with availability of the residents and choices. Like, at the end of the day, I feel if the senior residents have access to it, it could be in the OR that they like to make the decision to ditch the OR to go teach at the sim center is a tough one.
We've definitely had like most of our sessions, we've had fellows come along with the staff to proctor the session.
Maybe a question just about the program in general. I know we mentioned the sim curriculum being one of the strengths, and maybe if you could tell us a bit more about other strengths of the programs at uOttawa Gen Surg.
I think, I mean, one strength that I think really stands out to me is the culture of collegiality in our group. And you make a good point when you're asking about kind of residents coming in to help us, like senior residents coming in for our skills lab. But I just find with the setup that we have and kind of the culture that's been embraced over the many years, like before I started here, like senior residents are just always very willing to teach. I think they get it from when they're working with staff in an operating room that are really invested in their education. I definitely found that, especially as a junior resident, when I don't know exactly what the next move I might need to make in a surgery. The senior resident is able to, they're closer to my level of training. They were a junior resident not too long ago. So for having their perspective, being able to see common shortcomings early on in surgical training, it's really helpful in terms of learning those subtle things that you might not appreciate until someone points it out to you. And I think our the culture that's fostered in our program really facilitates that. And not only am I learning from staff when I'm in the operating room or in clinic, but from seniors on a daily basis.
Yeah, I think for me some of the strengths of the program I think I think we have a lot of structured teaching, which is definitely different from what I was experiencing when I was a resident. And I haven't been in many other programs recently, but I think it's been an improvement over the last few years, and I think that's something that's great and that we should be proud of. Like, you have HPB that have their 2 sessions, you have breast that have breast rounds, you have like the junior teaching, the junior half day, the senior half day, the junior lecture series. Like, I think we just have a lot of like planned structured teaching, and I do think that it makes for a great learning environment for you guys. I think it just shows that people are interested and dedicated to teaching you. And also, I think we have a really, there's a few things, but I do think we have a very big variety of because we have many close links with the community, like, and the tertiary centers. So you can do anything from going to Iqaluit to working in a tertiary center. So because you have all of that, and I think that also makes a residency program a bit better. And I think overall, like, to me, the best thing about this program is how much it adapts to things. Like, I'm just remembering how the program was 6 years ago or 10 years ago versus what it is now. Like, it's changed a lot, and all those changes were suggested or asked for by residents. And then we just implement them. So I think just the fact that the program is so responsive to suggestions from the resident is something we should be proud of. Any other questions about the program or anything at all? Or the CARMS process or whatever? I happen to also be responsible for CARMS, so.
Yeah, Dr. Raichi, I just have a quick question regarding the CARMS process. As you know, like, our external electives have been canceled, and some of us had electives that were scheduled in Ottawa in particular. So with that being said, I was just wondering, would you have any advice for just have being able to still express how much you're interested in general surgery despite having those opportunities canceled? I'm sorry in advance if it's such a hard question.
No, I think, yeah, I see what you guys are saying, and it is going to be challenging for us too in this context, like having like zero chance of getting to know you guys a bit better, like with the usual electives and we felt like we get a better chance to know you. This year, like there are pretty clear guidelines that have been published by the Canadian Association of Faculty of Medicine, I think, across the country. And so they've been very clear that they don't want us to start like new research project with potential applicants or give applicants any sort of extra chance to get to know us or get us to know them like a bit more. So obviously, like our hands are pretty much tied in terms of like doing anything, and we're not allowed to. I don't think we're allowed to go have a coffee with somebody who wants to apply. You know, like they're so very like, don't do this, don't do that. Like they left very few room for loopholes. So I think on the bright side, you guys are all going to be equal. What we ended up doing is we changed a little bit the way we're going to ask you to complete your personal statement for this year. So it's probably going to be more like a little bit more prescriptive to make sure that we get specific information about you. But yeah, it's all going to be equal. I personally assume that if you're applying to general surgery, you mean it. Like and I'm not super worried that people are going to apply and they're not going to be like 100% interested, because like,
Yeah.
I know historically general surgery has been a second choice for a bunch of people, but I'm very convinced that general surgery is actually a really bad second choice, because if you're not passionate about it, it's going to be really painful. So I don't think it's a good bailout option.
Mm-hmm. Okay, thank you for answering that question.
No problem.
But maybe on the topic of second choice, like for us, like a lot of changes in our year. So for example, now we're only allowed to do 8 weeks of elective in any entry discipline. So do you think it would look badly on an applicant who clearly went for 2 specialties?
No, I think we're conscious of that too, right? Like in the past, it was a little bit, it was getting a little bit strange. A number of electives people would have done in general surgery. Like there was a point where it would be like, sorry, did they actually do a year residency? Like what's going on? Like everybody had done like so many like elective observership and this and that. And it was just like, okay, like I get it. You want to be a general surgeon, cool. But like at the end of the day, like we're going to be training you when you start as a PGY1, and we're going to start the same place, and we're going to get you to become a surgeon in 5 years. That's the goal. So the number of electives, I don't think, again, like in the past when there was this opportunity, I think when people were like, we had applicants in the past that had done like 17 electives in ortho and 2 in general surgery, and then they were applying to general surgery, and that was a little bit suspicious, right? But right now, with everything the way it's working, I don't think it's not gonna have an impact. And we're all aware that you can, like, you're not allowed to go anywhere. Like you're not gonna be doing like 10 electives in your own institution with the same surgeons, like over and over and over again. Like there's a point where there's really no benefit to that anymore. And I would say that if you've taken this opportunity to either explore something else or learn a little bit more about another specialty, or just learn more, because like it's useful to know about cardiology or ICU or whatever, like as a general surgery resident too. Anything else? All right, well, it's 9 o'clock. Raj, any final words of wisdom?
Nope. I think just, echo kind of everything, that all the kind of generic advice that you get about CARMS, because it's all true. So like be yourself, and especially these days more than ever, when you don't actually get a chance to work with the people at every school that you're applying to, really try to spend your time trying to figure out what you want in a career, in a residency, and what you're getting out of it as well. Because a lot of time to be spending in a place or in a program that you really don't want to be there.
It can be a long 5 years.
Yeah. But if you enjoyed it, we'll go quick.
Right.
Thank you.
Thank you for coming, guys.
Yeah. Have a good night, everyone.
Take care, everybody. Bye.
Bye.
Thanks a lot. Have a great night.
Thank you.
Bye.